Okay, so we're still busy with obstetric hemorrhages, and today we are going to do antepartum hemorrhage. Now, before we go any further with obstetric hemorrhage, again, we have to look at the physiological changes that happen during pregnancy, and that is what caused our first sentence here that says obstetric hemorrhage is often not recognized. Because as we've heard now, as you've heard several times when we've done hypertension as well, there's an increase in blood volume during pregnancy. There's an increase in plasma volume, and there's an increase in blood cells. And because of that, blood loss is often underestimated because we only see signs of hypovolemia after quite a large loss of blood. We're saying here on the last bullet that the mother can lose up to 35% of her circulating blood. It's almost 2,000 milliliters before showing any signs of hypovolemia. So the normal signs of a drop in the blood pressure and a fast pulse are late signs of obstetric hemorrhage. So we also need to look at other signs of shock and other signs of bleeding to make our diagnosis. Now, if we look at causes of antepartum hemorrhage, and we define antepartum hemorrhage as a hemorrhage after 24 weeks of pregnancy. Remember, in our first lesson, we've said that miscarriages usually has a spontaneous loss of pregnancy before 24 weeks of pregnancy. So we associate bleeding before 20 weeks of pregnancy with miscarriages, and then after 24 weeks of pregnancy, we call it the antepartum hemorrhage. And then it's been associated with either abruptio placenta, which is the normal separation of a normally located or implanted placenta after the 20th or the 24th week of pregnancy. And the placenta previa is generally defined as the implantation of the placenta over or near the internal os of the cervix. Now, if we look at the abruptio placenta first of all, now what happens is remember we talk about the decidua basalis here. Now, decidua is the endometrium of the uterus during pregnancy, and what happens is that there's a bleeding here into this decidua basalis part, usually here behind the placenta, and that makes that there forms a hematoma behind the placenta, which makes then that the placenta separates further. And the placenta has been implanted in a normal place in the uterus, usually in the fundal part of the uterus. And now the bigger this hematoma or the placenta that has gone loose, obviously there's less blood supply to the fetus and it will compromise the fetus. Now, the problems with abruptio placenta, the clinical findings is usually this happens quickly. This happens much faster than in the case of a placenta previa, because we get this bleeding here, and the bigger, as we've said, the bigger the bleeding, the more it literally causes the placenta to get loose. Now, this usually sits here, this hematoma sits here between the decidua, and this is the myometrium, the muscle part of the uterus, and it causes quite a lot of pain. The pressure caused by this hematoma causes a lot of pain. Now, the other thing about the placenta previa is that usually, because it sits here, the bleeding is concealed. The bleeding is not coming out. If the membranes have ruptured and the bleeding is the bleeding comes here into the uterine sac in between the membranes and in the liquor, we might see first of all liquor that's blood stained, and then eventually the patient might bleed. So we only see visual vaginal bleeding in 78% of all patients. In the other cases, the bleeding is concealed. And also what is very important, we don't always see all the blood that's been lost there's quite a big blood loss here behind the placenta, and we only see a part of it coming out vaginally. So we can't really go on the amount of bleeding, and that's why we're saying the amount of bleeding is relative. Now, usually because of this placenta that's going loose here, and the large placenta, the larger the placenta going loose, obviously, the more non-reassuring the fetal status will be. And usually the fetal prognosis is not very good in the case of placenta abruptios. As we said, there's hypertonic contractions because of the pressure here on the myometrium, but also if there is bleeding in the uterus and the membranes have not ruptured, also the contents of the uterus is expanding, if I can call it like that, and that also causes hypertonic contractions. And that also often causes the uterus, when on palpation, to be very hard and tender. As the hemoglobin is usually low, and this is also not in comparison or in relation to the amount of bleeding that we can see. Now, the reason why I've put so many question marks here behind the blood pressure is, as we first of all have said that the blood pressure, that the signs of bleeding comes later, so the patient already has lost a lot of blood before we see a drop in the blood pressure. But very often, placenta abruptio or abruptio placentas are also being associated with hypertension, preeclampsia. So if we see a normal blood pressure, it might also be that it was quite a high blood pressure that has dropped to a normal blood pressure. So the blood pressure is not always a very good indication of exactly what is going on in this case. And then proteinuria is usually the indicator for us that the patient is having preeclampsia together with this abruptio placenta. Other signs of the abruptio placenta might be then hypovolemic shock, and that's usually a late sign. And also, again, this patient, this blood clot that sits here behind the placenta, uses a lot of coagulation factors, and therefore we very often get coagulation problems with abruptio placenta, and to the serious effect of disseminated intravascular coagulation, or DIC. Then we also get what we call a cuvular uterus, is what happens when this placenta, retroplacental clot, sits here, and as I've said, there's a lot of pressure here, and then gradually blood seeps into this, as I've said, this is the muscular part of the uterus, and blood seeps in here between the muscular vessels and cause a mottled effect of the uterus, and that's what we call a cuvular uterus. It's been named after Cuvier, which is a France, or was a France obstetrician. And the big problem with a cuvular uterus is that because there's such a lot of blood now here in the muscular vessels, between the muscular fibers, it makes that the uterus can't contract properly after the birth of the baby, and we sit with a big problem or possible problem of postpartum hemorrhage. Then there's the big possibility of renal injury that happens with a loss of blood, is usually because of the low glomerular filtration rate. One gets injuries to the glomerulus and eventually renal injury, and especially also when it's been associated with preeclampsia. Now, we have said that the fetal condition is usually not very good, so it's very important to confirm the fetal viability with the sonar. If the fetus is not viable, the prognosis is even going to be smaller, and then also it determines to a large extent how the rest of the situation will be managed. And then the other big possible problem, as I've said previously, is postpartum hemorrhage. Now, what I'm saying here under the NBNBs is that fetal death usually indicates a serious bleeding. It basically tells you that there's such a large part of the placenta has already been gone loose that the fetus has died already, and also as we've said, that there's a big problem with coagulation, and this fetal death with the seriousness of the condition tells us that there's a big possibility of clotting problems. Now, as I've said several times previously, there is a relationship between preeclampsia and abruptio placenta. So how do we know that the patient with an antepartum hemorrhage or abruptio placenta also has a preeclampsia? Because we have said just in the previous or two previous slides that the blood pressure is not a very accurate indication for us that the patient has preeclampsia or not. So we usually look at the presence of proteinuria. Will be a good indicator for us that the patient is probably having preeclampsia as well. Now, a second cause of antepartum hemorrhage is a placenta previa, and as we've said, the definition of a placenta previa is where the placenta has usually been implanted in the lower segment of the uterus, and we get 4 grades or 4 types of placenta previa, where the placenta is only not covering the cervical os at all, but it is situated in the lower segment of the uterus, where it partially covers the cervical os, like in this case, or even more, or totally covers the cervical os. Now, what happens here is the placenta is usually abnormally large, and the reason why and usually thinner as normal as well. And the reason why is that the placenta has now been sitting here in the lower segment of the uterus. The lower segment of the uterus, remember, becomes thinner, especially to the later part of pregnancy, and there's not a very good blood supply in the lower segment, and that is usually why the placenta is thinner than usual and larger. But then also, as the lower segment stretches then during the last weeks of pregnancy, it becomes that parts of the placenta can then separate and cause the hemorrhage. And especially when depending on the grade of the placenta previa, also now when the cervix starts being taken up and we get more effacement of the cervix, also parts of the placenta might separate, and that's usually causing the bleeding. Now, because this stretching of the lower segment and the effacement of the cervix usually takes place gradually, the bleeding of a placenta previa is initially not very big, it's minimal. And then gradually the bleeding tends to become bigger depending on how the cervix is being taken up or not. Now, if we look at the clinical findings of a placenta previa, we say that the vaginal bleeding can occur suddenly or gradually. In most cases, it's gradually. In the case of a grade 3 and 4, where the placenta is right over the cervical os, it can be suddenly, specifically when the cervix starts dilating. The bleeding might be suddenly and it might be quite a big bleeding. Otherwise, it's usually smaller and a gradual bleeding. And it usually starts during the 3rd trimester, as I've said previously, when the cervix starts to be, lower segment starts forming and the cervix starts to be effaced and being taken up. This bleeding is usually bright red and painless. It's bright red because it comes from right at the cervix. It comes immediately, appears. It's not darker red because, like in the abruptio placenta, it sits up higher and it takes a longer time to come to the cervix. And this is usually painless. Again, it sits right at the mouth of the cervix, so the bleeding just appears. It's not heaping up at some other place. Now, usually the bleeding, as we've said now several times, is usually the first bleeding is not profuse, and it might even stop. It might even go away. So part of the placenta, small part of the placenta goes loose, and then I almost want to say that wound heals, And then as the cervix, as the lower segment of the uterus stretches more, it appears again. There might be contractions or it might not be contractions depending on whether the patient is in labor or not. The uterus is usually soft and non-tender because blood is not heaping up in the uterus. It appears immediately in the cervix and it's been coming out the cervix. So this is a very definite difference from this abruptio placenta. The prognosis of the fetus is usually much better than in the abruptio placenta because it's usually smaller bleedings. And that's why I'm saying usually, as we've said previously, there can also be sudden and bigger bleedings depending on where the placenta sits. Now, under no circumstances, and this is very important, do we perform any vaginal or rectal examinations when a patient is having a vaginal hemorrhage. Now, the reason for that is I'm always saying a patient does not come into your labor ward and tell you that I'm bleeding because I have a abruptio placenta or a placenta previa. They come in and they say they are bleeding. And we're not 100% sure whether they are having a placenta previa or a placenta abruptio, where this blood is coming from. And if you do a vaginal examination and it's, for example, a grade 3 or a grade 4 placenta previa, you might put your finger right through the placenta and cause uncontrollable bleeding. Now, I know that in most cases where many patients are going for sonar examinations, and specifically in the private hospitals where they go for sonar examinations, often during their pregnancy, placenta previas can be diagnosed during pregnancy already. So the patient might come in and tell you that she has a placenta previa and bleeding because of that. But in all cases, one should never do a vaginal or a rectal examination till you're 100% sure where the bleeding is coming from. Now, as I've said in the previous slide, a patient seldomly comes to you and say, I'm bleeding because I have a placenta abruptio or I have a placenta previa. So you admit the patient with antepartum hemorrhage. And now I'm going to talk about the management of antepartum hemorrhages in general, whether it's now a placenta previa or a placenta abruptio, it doesn't matter. So first of all, we do a proper assessment. We do an assessment of the mother and we do an assessment of the fetus. Now, like in preeclampsia, in these emergencies where the mother is involved in the emergency, usually, as we've said with severe preeclampsia and eclampsia, the mother's condition is always the priority. So the same here in the case of the antepartum hemorrhage. The maternal condition is priority. So first of all, we assess the maternal well-being. We look for signs of shock. Emotional well-being is very important. Now, we're often in the cases of emergency tends to forget about the psychological aspects of the mother. But remember this, the mother is aware of the fact that something big is wrong. She's bleeding, she might lose a baby, etc. So even while we are doing our emergency treatment, it's very important to look after the emotional well-being of the mother as well, to assure her and support her and tell her what's going on, etc. Then the history of the mother is also very important. Now this we all do, obviously, depending on the seriousness of the condition. If there is time or in between what you are doing, you have to find out the history of the mother as well. Is this the first time that she's bleeding? In order, we've said that placenta previa, the bleedings tend to repeat. Or was she involved in a motor accident, which might be highly likely that the trauma caused the placenta abruptio, etc. So the history, the history of the present pregnancy, as well as the history of the bleeding, is very important for us to know. Vital signs important, and I've put hypertension here again in brackets, and even a normal blood pressure might be an indication that there was a hypertension previously. So we have to carefully look at the vital signs. Then we look for blood loss, the color of the blood, the amount of the blood loss, etc. And then we do an abdominal examination carefully to also, because we get a lot of information from our abdominal examination. We can see whether the patient is in labor because there might be contractions or not. Is there pain and tenderness? We've said pain and tenderness of the abdomen is been associated with rupture placenta because the uterus is then usually full of blood or filled with blood, or we have this big post-placenta, retroplacental clot as well. The consistency of the uterus, is the uterus hard or soft? The presentation and engagement might give us an indication of whether it's a placenta previa or not. Because if it's a placenta previa, there's no place for the presenting part to go into the pelvis. So we usually have a high head in the case of a placenta previa. The fundal height and circumference is very important for us, specifically the circumference of the uterus. And this is in the case of a placenta abruptio, very important for us to see whether the uterus is getting bigger because of blood that's inside of the uterus. Now, continuing with the assessment, are there signs of proteinuria, which might be an indication that this patient is also having preeclampsia? Now, it's very important for us to know whether the patient is having preeclampsia or not. Excuse me, because obviously when we treat hemorrhage, we do it with lots of fluids. And as you will remember from your previous course, where we have talked about preeclampsia and serious preeclampsia, we have to control the intake and the fluid balance of a placenta, a patient with a preeclampsia, very, very carefully. So that is why it's important for us to know whether this patient is also having preeclampsia. And that's also very important, a very important part of the history that we need to find out. As we've said, no vaginal examinations. And then the fetal condition, continuous CTG, so that we can also see how it is going with the fetal condition. And then we determine the degree of the hemorrhage. Is it a light hemorrhage? Is it moderate? Is it serious? And we will come to that just now. Looking at the signs, the vital signs, and the amount of bleeding that is present. And then we can come, if there's still time and the patient is not in serious, or if it's moderate to light, there's time to do a differential diagnosis, to take the patient for a sonar or ultrasound and to make 100% sure whether it's a placenta previa or a placenta abruptio, which might influence the further management of the patient. Now, sometimes it's not always possible to see the retroplacental clot in a placenta abruptio on a sonar. Very often it might look like part of the placenta. Now, to distinguish between a light and a moderate hemorrhage, we usually, in a light hemorrhage, there's slight tachycardia. There might be a slight decrease in blood pressure, also here depending on whether the patient is preeclamptic or not. And there might be slight vasoconstriction. The hands and the feet are cold. There are not really signs of shock present. So there's, and then also there might be a small hemorrhage visible as well. When we look at the moderate hemorrhage, we see that there's now more tachycardia. There's a decrease in the blood pressure. A systolic pressure, we get a systolic pressure of lower than 100 to 90 millimeters mercury. The patient might become restless and increase respiration. There are more signs of shock now. There's increased perspiration. She's sweating. There's signs of pallor. And then eventually also oliguria. And severe hemorrhage is then characterized by tachycardia of more than 120 beats per minute. We even get a more decrease in our systolic pressure of 60 millimeters mercury or lower even, and unusual pallor and cold, clammy extremities. So there's now real signs of shock present, oliguria and the patient is passing very little urine, and we also might get signs of confusion and she might lose a consciousness. Now, when we look at the differential diagnosis to determine whether there's now a placenta previa or a placenta abruptio, as I've said, a sonar is not always effective in the case of a abruptio. One might not be able to distinguish the retroplacental clot so easily. So we look also at all these signs that we have talked about several times now, whether there's pain present, which might be an indication of a placenta abruptio, a sudden onset as placenta abruptio in comparison with a more gradual onset of a placenta previa. The amount of blood that we see is what we get when we have a placenta previa, but in the placenta abruptio, the signs of shock might be much more than this amount of blood that we see, and that's visible. The color of the blood, that's usually more bright red in the case of a placenta previa. The degree of shock in relationship with the bleeding, and the degree of shock is usually more severe in the case of a placenta abruptio. As we've said, it starts more gradually in the case of a placenta previa. But we might also get immediate signs of real serious shock in the case of a serious placenta abruptio. The abdomen is usually soft and not tender in the case of a placenta previa, while it might be hard and tender, and there's a lot of pain associated with the placenta abruptio. And then, as we've said, we might get abnormal presentation or the head still high in the case of a placenta previa, but usually in the case of a placenta abruptio, the presentation and the engagement might be normal. Now, the principles of management are the principles of any management of any hemorrhage, as we've done previously also in the case of the miscarriage. So first of all, we evaluate the maternal condition and then decide on whether she needs resuscitation or not. As we've said, the fetal condition is second priority. Then we determine the fetal condition, what the fetal condition is, and then we might diagnose the reason for the bleeding. So what we usually do in the case of a light and mild hemorrhage, and this is usually the cases of placenta previa, as we've said, that might go away. So we do careful observations of the patient, and that's very important because it might get worse. So we have to check all the observations to see whether it stays constant and whether it stays good. Patient keep quiet. Absolute bed rest is not necessary, but obviously the patient should be as quiet as possible. Match blood for in case the condition is getting more serious, and then we can do a sonar to determine differentiate between a placenta previa or a placenta abruptio, because there's now enough time to do it, and one can do a speculum examination if the patient is in labor. If the patient is not in labor, there's no reason to do a speculum examination. And the reason for this is just to see if there is cervical dilatation. And in the case of a placenta abruptio, if it's not a placenta previa, one can do a normal vaginal examination and make a differential diagnosis then between a placenta abruptio and placenta previa. Now, in the case of severe hemorrhage, this is now where our emergency treatment comes in, and this is now where we act even before we know what kind of bleeding, what the reason for this bleeding is. So first of all, our observations again are very, very important, and continual monitoring of the vital signs here is so important. And then IV, again, a large borehole, 2 lines of IV, and we can put up a plasma expander, like Ringer's lactate, for example. We cross-match blood so that we can get blood as quickly as possible. And now the patient, because the patient is losing a lot of blood, because we are not 100% sure whether it is a placenta abruptio or not, we also take blood clotting time in consideration and coagulation problems in consideration. Now, we have here we've said that in the case of a placenta previa, in the placenta case, excuse me, in the case of a placenta abruptio, we get coagulation problems because of the formation of the large retroplacental clot. But we also get coagulation problems because of the massive blood loss in the case of a placenta previa. So coagulation problems might be bigger in the case of a placenta abruptio, but it can be present in both placenta previa and abruptio. Now, in the case of patients with placenta abruptio, with a big retroplacental clot, the patients might suffer from severe pain, and they really need a sedative or an analgesic. A sedative might be a good idea in any case, whether the patient is bleeding a lot or not. In the case of a placenta previa, also because, as we've said previously, these patients are usually very anxious and not sure what's happening with them. Give oxygen to increase the oxygen levels in the blood so that we can increase the oxygen levels in the placenta. Because of the hypovolemia, we want to get as much as possible oxygen to the fetus. And then, like in the case of any hemorrhage, it's very important to monitor the intake and the output of the patient very carefully. Now, we have said that we put on 2 large bore cannulas of IV lines. We send off blood samples as quickly as possible. We give IV fluids and blood if possible. We catheterize the patient so that we can monitor the intake and the output very carefully, and we are aware of possible coagulation problems. And continual monitoring of vital signs are extremely important. Now, the possible complications of antepartum hemorrhage, I think we have talked about them many times now. The biggest one is maternal shock and obviously eventually maternal death. The possibility of anesthesia and surgery, because in many cases it might end up in a cesarean section. Postpartum hemorrhage in both cases, abruptio and the placenta previa, is a big complication. In the case of abruptio, we have talked about the possibility of a cuvulaire uterus, and because the uterus was extended to such an extent, if there was concealed bleeding and with all the blood in the uterus, it struggles to contract after the birth of the baby. And in the case of a placenta previa, the placenta, as we've said, is usually larger than normal because it implants in the lower segment, and also the lower segment can't contract as well as the upper segment during the postpartum period, and that's why our possible complication of postpartum hemorrhage is so big in both cases. Maternal and or fetal death, and as we've said, the fetal prognosis is usually worse in the case of a placenta abruptio. We have talked about the possibility of DIC and coagulation in problems in general when it is a large bleeding, and then renal failure specifically in the case of large hemorrhages. Okay, now, why is it important to remember that many patients with abruptio placenta have underlying preeclampsia? As we've said, there's often an association between the two. Now, first of all, as we've said, our blood pressure measurements might be wrong. We might have signs of shock, but we have a normal blood pressure. So we have to take that into consideration when we look at the overall blood pressure and vital signs of the patient. Now, these patients with abruptio placenta need active resuscitation. And as we've said, that with active resuscitation, obviously there's a lot of intravenous fluids involved. And in the patient with preeclampsia, we have to control the fluid balance, the intake and the output of the patients very, very, very careful. So that is very important. Now, After the resuscitation of a hypertensive patient, this is now in the case of now a rupture of placenta or a bleeding, the patient has now been resuscitated. We get now a normal, the problem is over. The patient might become hypertensive again. Now we're talking about preeclampsia. So the bleeding problem has been removed, but then the patient is hypertensive again. So we have to treat the patient for the hypertension. So that is very important, and specifically we can treat with Adalat, but when there are signs of imminent eclampsia as well, obviously we need to treat the patient with magnesium sulfate as well. Now we have said that several times, is that the preeclamptic patients are hemodynamically very unstable. We have to control the fluid balance very, very carefully, because if we do overload the fluid, we might end up with pulmonary edema and maternal mortality because of that, instead of the bleeding. And that brings us to the end of this lesson with antepartum haemorrhage. And again, you have to complete your quiz before you can continue to the next lesson.